Good morning everyone. I am Anuja S. Varghese, lecturer of Emmanuel SR College of Pharmacy. Today we are going to discuss about the topic renal system, renal failure. Acute renal failure. Acute renal failure is an acute and potentially reversible irritability of the kidneys to perform their normal functions to maintain homeostasis. Etiology. Pre-renal factors, intrarenal ARF, and postrenal or obstructive. Pre-renal factors. Osmolality is high, specific gravity is less than 1.020, decreased renal perfusion, tubular function normal. Non-specific symptoms: fever, dehydration, tachycardia. Example: shock, CCF. Intrarenal ARF results from injury to kidney, large amounts of calcium and uric acid excretion. Sodium cannot be conserved, urine cannot be concentrated. Symptoms: nausea or vomiting, hypertension, oliguria. Example: HUS and GN. Postrenal or obstructive, delayed voiding after birth, electrolyte imbalance, a poor urinary system, abdominal mass. Urine osmolality and sodium levels are unaffected. Example: calculi and trauma. Phases: initial, oliguric, diuretic, recovery. Initial. Renal damage is occurring, the child may be asymptomatic. Oliguric. Less than 1 milli per kilogram or hour of urine, impaired glomerular filtration, waste cannot be removed, uremia develops, neurotoxicity, CCF, HTN and anemia. Diuretic. Last 2 weeks, cellular regeneration and healing, gradual return to normal, dehydration and electrolyte imbalance due to excess urination. Recovery. It takes months, it felt untreated, it result in fluid overload, electrolyte imbalance, uremia and coma. Clinical manifestations: severe oliguria or anuria. Child may be markedly well or extremely sick. Nausea or vomiting, lethargy, dehydration, acidotic breathing, altered consciousness, irregular cardiac rate or rhythm, edema, hypertension. Diagnosis: carefully history taking vomiting, diarrhea, fever, other renal disease. Laboratory investigations: anemia, raised serum, creatinine level, blood urea, electrolytes, pH, bicarbonate and complete blood count, reduced C3. Urine examination: proteinuria, hematuria, presence of casts. USC: structural abnormalities, calculi. IBP: acute tubular necrosis. Radionuclide studies evaluate GFR, renal blood flow, renal biopsy, ultimate cause. Pathophysiology: due to etiologic factors, renal vasoconstriction, arteriolar constriction, function of nephrons, damaged tissue cells and RBCs. In renal vasoconstriction, decreased glomerular filtration rate, sodium and water retention and edema. Arteriolar constriction, HTN, increased circulatory overload and sodium retention. Function of nephrons, failure of excretion of H2 ions, increased production of acids, metabolic acidosis. Damaged tissue cells and RBCs, disturbed sodium and potassium exchange, decreased extracellular potassium overload, hyperkalemia. Treatment: medical treatment, fluid and dietary restrictions, use of diuretics, maintain electrolytes, may need dialysis to jump start renal function, may need to stimulate production of urine with the IV fluids, dopamine, diuretics, etc. Hemodialysis. Nursing interventions. Monitor lab results. Watch hyperkalemia symptoms, malaise, anorexia, or muscle weakness, ECG changes. Watch for hyperglycemia or hyperglycemia if receiving TPN or insulin infusions. Maintain nutrition, safety measures, mouth care, daily weights. Assess for signs of heart failure, skin integrity problems. Prognosis. Mortality rate of ARF is about 20 to 40%, which is influenced by the cause and duration of renal failure with the severity of pathological changes. Poor prognosis is related associated sepsis, HUS, prolonged anemia, cardiac failure, hepatic failure, and respiratory failure with the delayed initiation of treatment. Chronic kidney disease, chronic renal failure, end-stage renal failure. Chronic renal failure. What do you mean by chronic renal failure? It is a permanent irreversible destruction of nephron leading to severe deterioration of renal function, finally resulting to end-stage renal diseases. Etiology. Cause below 5 years of age is mostly congenital anomalies. After 5, that is acquired glomerular diseases, hereditary diseases. Glomerular diseases, congenital anomalies, obstructive uropathy, miscellaneous. Clinical manifestations. Early symptoms, late manifestations, indications of poor prognosis. Early symptoms: weakness, anorexia, nausea, failure to thrive, unexplained anemia, osteodiastrophy, growth failure. Late manifestations: gastrointestinal bleeding, pericarditis, congestive heart failure, altered sensorium. Indications of poor prognosis: convulsions, coma, cardiomyopathy. Diagnosis. Blood examination. Decreased hematocrit, hemoglobin percentage, sodium, calcium, HCO3, increased potassium and phosphorus. Renal function test. Gradual increase in BUN, uric acid and creatinine. Urinalysis. Variation in specific gravity, increased urine creatinine, change in total urine output. X-ray. Chest, hands, knees, pelvis, spine to detect bony defect, ECG, IVP, MCU, radionuclide imaging. Extent of complications. Other abnormal findings: metabolic acidosis, fluid imbalance, insulin resistance. Pathophysiology. In the early stage of diseases, child remains asymptomatic. Advanced renal damage will occur only in late stages. Increased numbers of nephrons are destructed at various degrees and a few remain intact but hypertrophied and functional. This leads to insufficient adjustments in fluids and electrolyte balance. As the disease progresses to end stage, severe reduction in number of nephrons occur and the kidney will not able to maintain fluid and electrolyte balance. The accumulation of various substances in blood result in complications. Stages of chronic renal failure. Diminished renal reserve, normal BUN and serum creatinine in absence of symptoms. Renal insufficiency. Glomerular filter rate is about 25% of normal. BUN creatinine levels increased. Renal failure. Glomerular filtration rate less than 20% of normal, increasing symptoms. ESRD or uremia. Glomerular filtration rate less than 5 to 10 percentage normal. Creatinine clearance less than 5 to 10 ml or minimum, resulting in a cumulative effect. Complications: azotemia, metabolic acidosis, electrolyte imbalance, CCF, HATN, severe anemia, growth retardation, delayed or absent sexual maturation. Management: conservative management, correction of reversible component of renal dysfunction, preservation of renal function, treatment of metabolic and psychosocial problems, optimization of growth, preparation for treatment of ESRD, treat for infection, accelerated hypertension, CCF, obstruction of urine flow to improve renal function. Dietary therapy: low protein diet. Severe protein restriction may produce protein calorie malnutrition. Diet should consist of 100% RDA for calories. Protein should be of high biological value and should comprise 6 to 10% of all calories. Salt restriction in patients with hypertension and fluid overload. Patients with salt-losing nephropathy should take a liberal amount of salt and water. If the glomerular filter rate falls less than 10 ml or minimum 1.73 molecular potassium intake should be restricted. Hyperkalemia may develop. Vitamin D is essential to raise the serum calcium and suppress parathormone secretion. Thank you.